Assalamu alaikum. I hope everybody can hear me. अगर एक कोई response आ जाए ना तो हमें पता लग जाए कि मेरी आवाज सुनते कानों तक जा रही है. That silence. Should we start, Ikra? Sure. Assalamu alaikum. As most of you know, I'm Dr. Usman Aftab Ahmad. आपके मारूफ hospital से आज it was my turn for the grand round, and in the spirit of Ramzan, ताकि सबको भूख ज़्यादा लगवाएं, we've chosen the topic in nutrition in chronic liver disease. So we'll try and shed some light on this. So now we'll discuss some myths around chronic liver disease as well and the nutrition in it. Basically, malnutrition is very common in chronic liver disease. Although if you picture somebody with chronic liver disease, you will imagine somebody with a big belly, high BMI, because non-alcoholic fatty liver disease is also a leading cause, especially in our part of the world, of chronic liver disease. Hence, we don't relate it to the conventional picture of a malnutrition. I think my picture probably on this computer is not showing, but anyways, we can all use our imaginations. So malnutrition correlates with prognosis. Cirrhotic patients with protein calorie malnutrition have higher rate of encephalopathies, infection, and obviously, in essence, mortality. Malnutrition for in a country like us, where health system is largely privatized, will have significant implications on the length of stay, which means more cost for the patient as well. Hence, nutritional therapies can reduce complications and mortality. So malnutrition, at the right bottom of your screen, we can see this pictorial demonstration of malnutrition. Does not need to be associated with just weight, because it comes in different forms and affects different BMIs in a different way. So the most important thing to discuss is the protein calorie malnutrition. Protein calorie malnutrition is general atrophy due to the deficiency of calories and proteins. This happens up to 90% of patients with the chronic liver disease. It goes up to 100% in candidates for liver transplant for one reason or the other, and because of the longevity and the severity of the disease. There is micronutrient deficiencies. Progression of the liver disease correlates with the severity of malnutrition, and this is across the board. This does not depend on the etiology, because this presentation I did abroad as well, so you might find some references to alcohol induced liver disease as well. But I can tell you across, we'll have some data later on as well, that across the board, no matter what the etiology of chronic liver disease, malnutrition plays same and equal role. So a pictorial demonstration of what pathogenesis of malnutrition in liver disease can be like. It's multifactorial. Normally, it's starting from the basic, which is altered or abnormal nutrition intake. Now, you can imagine somebody who's got a heavy belly with lots of fluid, or not even, but your metabolism is all around and haywire. So the first thing that happens is distaste. You lose the taste of food. This leads to nausea, anorexia, especially in people with alcohol, because they had a lot of their calorie coming from the alcohol intake. So this is one of the first things they stop as well, or we rather ask them to stop. So they lose their biggest source of nutrition. Similarly, the food becomes unpalatable, because one of the first things that we would do is salt restrict. And you can, if you don't agree, just try a day with no salt, and you will see that there is actually no taste to the food, and people just leave it. Tense ascites and gastroparesis, this develops because of as a sequelae of chronic liver disease, which again, because of normal pressure as well, and dysmotility, causes problems with digestion and feeling the need to eat. Decreased intestinal absorption is also one of the key reasons, because a lot of these people will develop um, fat soluble vitamin deficiencies, thiamine deficiencies. Portal hypertension will affect the gut, uh, in specific the small bowel and the stomach, which causes decreased absorption. Bacterial overgrowth is very common in such cohorts as well. Metabolic disturbances, glucose intolerance develops. This is more prevalent in non-alcoholic fatty liver disease as well, which leads to diabetes. And a lot of these patients who have, regardless of the etiology, can develop latent or delayed diabetes as well. Now, this results in dependence on fat as energy substrate. Now, this is very important, and we will have a more discussion about it later on as well, because the body starts metabolizing fat. Once it starts doing that, the fat in your belly and under your skin starts to go. So this causes sarcopenia and loss of all the skin turgors and everything. So they might have a big belly, but if you touch their arms, the skin thickness goes really down. Protein catabolism starts, hence the loss of the muscle or the muscle wasting starts. This affects the neurotransmitter synthesis and decreases the control on our extremities. Other factors. Some cirrhotics are in a hypermetabolic state. So they need more energy than usual because the liver is trying to, whatever part of the liver is left, it is trying to regenerate itself. The next bit is important because this is where I want us as a colleagues and our juniors to concentrate as well, which is doctor factors. Patient lands in our ERs or our clinics or our inpatients, and couple of things that are our first responses that we do, or the nursing is even the first response that we do. So we do large volume paracentesis. This shifts a lot of volume across the body, which affects the nutrition, which takes out protein as well. We try to replenish it with the human albumin solutions, but this is a large volume shift. What if I reflect on my practice? The first thing that you do when a patient comes in, what do is starve the patient. So this is our hobby as doctors. We just starve them. We can starve them for investigations like endoscopy. We starve them for scans, ultrasounds, whatnot. We just like to starve unless we get the plan. This patient is not going to wait. The metabolism will keep on going. The body will start eating or keep on eating itself. Long night gaps. I will show you some interesting data later on in our talk as well. But if you can imagine, a patient comes in, we give them even hospital food, we give them the morning breakfast is around 7 to 8. Then there's a midday meal which runs between 12 to 1, and the dinner is usually served around 6 to 7. Now, if you imagine between 7 in the evening till 7 or 8 in the morning, it's about 12, 13-hour gap. That is sort of fasting. It's a very long night gap, which basically leaves such patients with chronic liver disease, especially cirrhotics, without any food for a very long time. And then again, medications like lactulose, prokinetics, diuretics, they all affect the absorptions and the dietary effect and the malnutrition, promote the malnutrition as well. So, nutritional assessment. I think this is a simple thing that probably it should start down from the nursing. And in the modern world and Western world, to be honest, this is done by the admission nurses. I know in our part of the world, because patient load is too much, sometimes it becomes difficult, but at least a thought about it, initial assessment of weight loss, initial assessment of diet, what they are taking. If it starts from the nursing point of view or the stage where the nurses are admitting patients, this trickles down then to the junior doctors and keeps under consideration when it reaches to the clinicians as well. So nutritional assessment, there are lots of tools that have been discussed and developed. Weight is unreliable because, as I said, if you've got ascites, then it is very difficult to assess their weight because we generally go by dry weight. Albumin, mostly, if not all, is undersynthesized, so it's not a good nutrition marker at all. Dietary records is good. I think this is a good starting point to start from allied health services to start keeping a dietary record, like food charts and all. History taking, we all have emphasized in every clinical scenario, regardless of what the cause or symptoms are, history, history, history. This is one message for the junior doctors. You have to start taking history. And in such chronic disease patients, regardless whether they have chronic liver disease, any etiology, any cause of chronic disease management starts with history of nutrition. Must scores have been described. A lot of other scores have been discussed. There are a couple of factors we'll discuss in a minute. This is a chart from Baipin. It's a busy sheet. We can share it with our colleagues as well. I'm sure we've got similar papers developed already. Basically, we would like to concentrate on medium and high risk groups. One of the easier things is weight loss in patients, just checking in the last 3 months or so how much weight loss has happened. Are they eating properly or not? I think this is a good starting point. And then the skin turgors and skin depth, obesity records. And once we triage them as at risk of malnutrition, and just as a point, this is not just for liver patients, this is across the board. This is the scoring system that is used for assessing nutrition in all patients. But these can be modified from in hospital state, and we do have some similar sort of things in place here as well. Whether they are followed or not is another question. Ways to assess the malnutrition, again, anthropometries. I think these are specialist tools used by dietitians. I've not seen it used here, but this is basically skin fold thicknesses, hand grip tests. So we can probably improve on subjective global assessment. I think this is where areas like Pakistan and some developing countries can concentrate on, which is some factors that are easily seen, like weight loss, change in dietary intake, presence of gastrointestinal symptoms, functional capacity. This is the scoring system are available on apps as well, on online as well. I don't want to be advocate of yet another paperwork that goes in a file of umpteen papers that are just filed in the notes, but I think this is something to consider for especially across the board in chronic patients of any etiology. This is an example of different sort of hand grips. I'll speak to Nida if we've got here as well, and then we can show junior doctors around. It's a good activity to check your own malnutrition as well. And you would be surprised that people who are like, who've got increased BMI like me might have this lower than what we think about ourselves. So guidelines, usually we follow ESPEN in the European side, and I follow ESPEN as well. They've done work on liver disease. But if you see on the top, even in the modern Western world, nutrition is not that high on the agendas usually. This paper is from 2016, sorry, my apologies, 2006, and they come up with recommendations and some guidelines for chronic disease nutrition management in liver patients. So a snapshot of these guidelines would be, and this is where we start busting some myths around chronic liver disease and ascites patients. So assessment in general, like we discussed, anthropometries and skin assessments, protein calorie malnutrition assessments. Again, the energy requirement, we'll discuss this in a bit more detail. So energy requirement in cirrhotic patients is 35 to 40 kilocalories per kg body weight. In a normal healthy person, usually it is down. So it is surprising that patients with chronic diseases use more energy or require rather more energy than a healthy individual. In healthy individuals, it'll it is something around 25 to 30 kilocalories per kg body weight. It comes across in women around 2000 kilocalories in a day, and 2500 kilocalories in men as normal, healthy individuals. But the energy requirements are higher in patients with chronic liver disease. Application of supplements, you can see it improves the outcomes, and the evidence is grade A in use of supplements. The next is tube, which is the NG feeding. NG feeding, I think a lot of anxiety comes around when patients have varices. We have put NGs in people who have varices, people who have had banding. It has no issues with any possible complications. It is safe to do. The evidence is very high that they need nutrition. Enteral nutrition is of paramount. So please don't think of me as crazy as I go across the hospital and tell everybody to put NGs in liver patients, because the evidence is overwhelming in patients who require nutrition. The nutrition is a very important marker in improving the outcomes. Whole protein is generally better. It busts. I've got another chart in coming slides, because when I was in my early years, there was lots of talk about protein restrictions in patients with chronic liver disease, especially in hepatic encephalopathies, that we should restrict protein. But this has over the years gone out of fashion. There's evidence that protein does not cause any problems at all with encephalopathy. Branch chain amino acids have been used, expensive stuff, but they have been used. I personally would keep them for recurrent hepatic encephalopathies with enteral feeding if they are not getting better. And last but not the least, we can see the outcome with better nutrition. The improved survival rate in cirrhotics is quite significant. So a bit on some specific conditions as well. As I said, this talks about alcoholic steatohepatitis, but this can be translated across any form of steatohepatitis or hepatitis as well. Nutrition assessment, again, we start with early assessment, energy intake, keeping in mind the 35 to 40 kilocalorie kg per day requirement for patients. Use of supplementary enteral nutritions, again, preferably oral. Parenteral, there is data that parenteral nutrition does not improve survival. In fact, in some cases, because of need for long lines, this can have adverse effects, especially in terms of sepsis. This is just similar to, this talks about cirrhosis, and you can see between steatohepatitis and cirrhosis, not a lot of thing changes. Their energy requirement, patient's energy requirement, is still on the higher side, and we need to meet it. And to consider, to put into context, because Ensure or likewise supplements that are prevalent in our community, one dose of Ensure, which is about 5 spoonfuls, only gives you between 230 to 250 kilocalories. That's it. So even if they drink 10 of them, they are barely meeting the 2500 requirement for men. So we will talk about it in a minute as well. But just to put into context, it's very difficult to get that high amount of calorie requirements by just eating what normal diet comprises, especially in patients who've got high energy requirements. Hence, the force on or emphasis on enteral and NG feedings. So this is just a pictorial of a study that was published. This is based on basically what we were talking about, the nighttime increased fasting. You can see change in body protein is quite significantly higher if patients are given nutrition at night time as well. So the dark block is nighttime nutrition, and the clear white ones are daytime, and quite significant if we in fact, one of the studies even show higher protein improves hepatic encephalopathy as well. So we come to an end towards my monologue here. Some take-home points. I would recommend do not protein restrict. Even if it's encephalopathy, think about their requirement first. Branch chain amino acids have a place. Get specialist input from renal, from hepatology. Don't just protein restrict. Encephalopathy should be treated aggressively before we start thinking about protein restrictions. More meals are optimum. As we discussed early, because of gastroparesis, ascites, large volumes cannot be taken at a time. I would recommend small, frequent meals. Enteral feeding should be considered early. The reason I say that is, again, it takes the control out of the family and attendants and the patients, and gives it slightly more control to the clinical staff, because I'm sure a lot of us have seen this in our practice. The moment we establish a route for nutrition, the first thing that goes in patient's mouth is chai. I have had discussions and fights and arguments with the patients and their attendants is, why are you doing this? Even in patients we've seen, we put peg tubes, the first thing that goes in is tea, because patient likes the taste of the tea. If it's going in the stomach, it does not matter what the taste is like. And one advice I give them normally with the supplements as well, the supplements should not be taken at meal times. They should be between meal times, because whatever the patients can manage eating, uh, even if it's a half bread, a couple of slices, a glass of milk, or whatever they can manage, they should manage it at their time of meal. And all the supplements, the dietary supplements, the calorie intakes, the protein shakes, whatever we are trying to give, that should be between meals rather than the meal times. Water restriction should not be done unless the sodium is less than 125 milliequivalents per liter. One thing I would say, this has come across and developed on then over the last few years, is we used to stop people from salt. As we have discussed early, stopping salt just makes the food unpalatable. They will go off their food 100%. The compliance is not going to happen. What I, in my practice, advise patients and relatives is, you make food in low salt and do not put added salt in it. Whatever the salt is used in low quantity in making food, just be at that. And one of the guides for that would be, if family member eats the same food for the patient, there is need to add more salt. And this is one of the crude criteria which I follow, because we've tried restricting salt. Patients would come and say they don't eat salt. This never happens. It's very difficult. Fat soluble vitamins, folate, thiamines, calcium supplements. Yes, I would recommend giving them appropriately, not willy-nilly, but appropriately when required. Dietitian input is important, but our take-home message from this, if you don't remember any of my monologue and my rant, is feed, feed, feed. Uh, that's the treatment, sometimes even more than antibiotics and the medications that we give them. And thank you very much for listening. We'll have questions.
Ji, Assalamu alaikum, Usman. Thank you so much for your talk. Can we comment?
Yes, please.
I think it's an extremely important area you touched, and Ramzan is a good time to touch on it, I suppose. But it's interesting how hepatic management has evolved over the last few decades, from that very low protein diet to something which is much more liberal. And similarly, we find similarity even in acute kidney injury, where people used to restrict protein, and now they say, no, you need to give the protein, you need to give the calories, you need to support them nutritionally, and just dialyze them frequently. So a lot of your cirrhotic patients have either type 1 or type 2 hepatorenal, or they have low muscle mass, so their creatinines may be quite misleading, and they may have some renal dysfunction. And we usually, obviously, the kidney part comes in, where a little bit of protein restriction decreases hyperfiltration related injury. So how do you balance that in your patients that have type 2, in particular hepatorenal? Type 1, so I know it's just going to be a little more downhill rapidly, but type 2 hepatorenal, how do you manage the protein in those, realizing that both organ systems are involved? What's been your practice?
So coming on your first point, I think I agree with Professor Saab. I think a lot of this change in practice is driven, one, by research, of course, but by compliance as well. Because you take all the goodness from food out of patients' lives, and then it becomes really difficult, and the compliance becomes an issue. So I think a lot of this research has stemmed at least from this notion that we should feed. Patients with HRS, I agree with you, like you said, in chronic renal diseases, that yes, you will feed them and then we'll see what comes next. I think the similar approach comes in HRS as well, hepatorenal. A lot of the times we give them artificial human albumin solutions as well, sometimes on a higher doses. And I agree we liaise with yourself and renal physicians, and we just feed them, and then we can dialyze, because I think the mortality is going to be, if you develop HRS, your mortality goes higher anyways. So the idea of organ preservation is very high up. So we have to protect the liver as well. And then obviously we have got a service, or sort of a service, which is not always possible, renal dialysis in patients. But I think we take it as, let's get the proteins up first, and then we will grovel and beg you for dialysis. So this is what
Sure. No, and I think I appreciate that thing, and I think that would be the appropriate solution when you have hepatorenal. The other thing is regarding your nutritional assessments, and you're right that we don't really see the triceps, skin fold thickness, and other things being done. So my first question is, who are the full-time nutritionists you have in the team at this point that we can also call upon? Okay, I'm not aware we have full-time nutritionists right now, or do we have one?
We do have one. So Nida is doing a good job. I wouldn't expect, or I wouldn't say she does hand grips and skin fold thicknesses, but I think as we go along between renal and ourselves, because I think gastroenterology and nephrology probably has the highest cohort of these malnourished patients, so we can develop on this. So Nida is available most days.
Okay.
And she does go around helping a lot of surgical patients. I think we need to get her involved in lots of medical patients as well.
Thank you so much.
So, Dr. Salman here. Sir, I have one question.
Yes, please.
Sir, the recommendations you shared is for the decompensated for the CLD, or it is equally true for non-compensated CLD?
So this is across the board. I think, to be honest, if I were you, I would concentrate or make this change more in patients who are compensated, because that's probably the time you can make change in their longevity, in their outcomes, in their morbidity. Once the patient decompensates, like they get high child PUC scores, the clock starts ticking anyways. So sometimes you miss the boat. So I would say, and to be honest, I would not even stop at chronic liver disease. I would uh, even come before that, when we establish that patient has a liver disease or even hepatitis is of any sorts. Once there is a suspicion of malnutrition, these things should be started straight away. I have put NGs on people who have had hepatitis A, because we know more in most, if not all, is self-limiting. So nutrition goes without etiology, without the condition of the liver. This is one of the first things. If you see an organ like liver or kidneys getting affected, I think this is one of the first things that should come in your initial assessment. What am I doing with nutrition? Because we have seen drastic effects in patient hospital stays and patient getting infections if we fast them or don't start nutrition appropriately. This is why I touched on even putting NGs in variceal patients. If it, firstly, they will know there's no enough data that you will cause bleeding by poking their varices. Hands on. That's it. Hands down. If you do, even then we have services we can stop it. So I would suggest, coming back to your specific question, yes, for compensated liver disease as well, nutrition, nutrition, nutrition.
Okay, thanks, sir. Good.
Okay, thank you very much. I think hopefully soon, someday, we will come and make this face to face, because I have no idea who's sleeping, who's cursing me for wasting half an hour of their day. But I'll take it on face value that we did a good job. So thank you very much. And happy Ramzan ji. You?